So today's program, we have the first session in a little bit on the importance of adipose tissue in people living with HIV. We have abstract-driven presentations, satellite symposium supported by MSD on weight gain and aging and risk factors to keep in mind. In the afternoon, we'll talk about bone and issues in people living with HIV and a poster viewing session. Next slide, please. That satellite symposium will be, we think, particularly interesting. That's right after the abstract session, where Dr. Lacombe will talk about women of not childbearing potential, and Dr. Vengal will speak to us about aging as a risk factor for weight gain in people living with HIV. Next slide, please. So this session on fat and adipose tissue that I'll be chairing it has two terrific speakers. Our first speaker is Dr. Jordan Lake. Dr. Lake is Associate Professor of Medicine at the McGovern Medical School, University of Texas Health. Medical school and residency were done at Baylor College, so she's a real Texan here. ID fellowships and her master's degree in clinical research at UCLA. She's active in both the combined Maxim-Wise studies, especially focusing on in-metabolic issues, and her clinical practice is focuses on adults with HIV, in particular women and transgender. Her research focuses on metabolic and aging-related complications of HIV and ART, and it's a pleasure to introduce Jordan to you today.
Good morning, and thank you to the organizers for asking me to speak today. We'll briefly cover the effects of HIV, ART, and aging on both muscle and fat. So just as a brief overview, we're going to start the talk speaking about adipose tissue and adiposity in people living with HIV, including weight gain on ART. We'll then move on to talk about muscle, and mixed in along the way, we'll talk about the effects of aging, virus, and antiretroviral effects on both of these tissue depots. And finally, I'll close with some take-home points. So just as background, aging, HIV, and ART are all associated with changes in muscle and fat, as this audience well knows. They're also associated with the development of cardiometabolic disease, which is the ultimate reason that we care about the tissue level changes. But the intersection of these is still not fully understood. As time has gone on, our knowledge of the virus of specific effects has improved, as has our knowledge of ART effects, although the effects of ART really have evolved as ART has evolved, such that we've gone from focusing on lipodystrophy and mitochondrial dysfunction to, with more modern ART, the problems of generalized weight gain, more subclinical adipose tissue changes, as well as lipid and glucose abnormalities and the risk of cardiovascular disease. So how may HIV and ART affect adipose tissue function? First, they induce a pro-inflammatory environment with immunologic dysregulation. Second, there's suppression of PPAR gamma with altered lipid and glucose metabolism at the tissue level. Third, both HIV and ART, specifically protease inhibitors, have been documented to stimulate the renin-angiotensin system. And fourth, fat is a reservoir or sanctuary site for HIV. This is due both in part to early seeding of the adipose tissue by HIV early in infection, and due to low ART penetration by some classes of agents. And clinically, when we're thinking about adipose tissue dysfunction, there are three intersecting syndromes. So we're all familiar with lipoatrophy, lipohypertrophy, and visceral fat accumulation, as well as generalized obesity. And increasingly, especially as our population is aging, we're seeing overlaps in these clinical syndromes. Additionally, HIV and antiretroviral therapy have to be layered on top to provide, where they cause additional effects in the tissues that complicate our understanding of both these clinical syndromes and how they may be treated. So what are the virus-specific effects in the adipose tissue that lead to metabolic defects? In untreated HIV, there's a catabolic state characterized by wasting, increased triglycerides and LDL cholesterol, and low HDL cholesterol, as well as mitochondrial dysfunction and depletion, adipose tissue inflammation, and insulin resistance. These viral effects persist during ART due to the presence of viral protein R, or VPR. In fact, replication-competent virus or intact virions are not needed to trigger these metabolic effects at the tissue level, simply the presence of VPR. So during early HIV infection, the tissue is seeded with whether or not there's replication-competent viruses. Doesn't matter. The presence of the viral protein in the fat long-term leads to these consequences, which are primarily suppression of adipose tissue PPAR gamma and glucocorticoid receptor activation, as well as macrophage and T cell infiltration into the adipose tissue, creating a pro-inflammatory environment, stimulation of apoptosis and lipolysis. And these viral effects may differ by sex. There are estrogen receptors in the fat, and some data exist to support the hypothesis that viral effects differ through estrogen receptor modulation. However, the complete mechanisms of these have not been worked out. What we do know is that HIV's metabolic effects are mediated through inflammatory pathways. So this figure primarily shows what happens with obesity. Moving from left to right, you see that fat tissue goes from regular round adipocytes with a small lipid droplet to large engorged adipocytes with irregular lipid droplets. This is a highly pro-inflammatory state that the cells are under a lot of stress. They send out distress signals, which causes influx of immune cells, release of cytokines that ultimately cause tissue inflammation, tissue hypoxia, necrosis of the adipocytes, and metabolic dysfunction marked by insulin resistance, lipolysis, and free fatty acid release. HIV, in fact, mirrors these tissue level effects, but what we don't know is whether HIV and obesity, those effects at the tissue level are synergistic, additive, etc. I want to briefly touch on lipoatrophy, such that really we're talking about its relevance and as a legacy effect in persons exposed to thymidine analog NRTIs. So the fat wasting and mitochondrial dysfunction that are characteristic of these agents is associated with a pro-inflammatory tissue environment and adipose tissue fibrosis, which subsequently leads to dysfunction. And since most of these changes are irreversible, persons who were exposed to them in the past are still suffering from these effects. And any new ART effects or any new weight gain effects have to be layered on top of these. And indeed, in the max cohort, men with thymidine analog exposure had significantly more metabolic syndrome components after adjusting for other contributors. And then we have to just think about generalized obesity. We are going to talk in a minute about weight gain with ART initiation, but as you can see in the left-hand panel from a cohort in the southern United States, in some areas, significant portions of people living with HIV are overweight or obese before they even start antiretroviral therapy. Here, it's well over 50%. And then we know we're going to start ART and people are going to continue to gain weight, and we're going to exacerbate these traditional obesity-related problems. A second factor is how people gain weight. This is illustrated on the right. If you are not overweight or obese at the time you initiate antiretroviral therapy, we don't know how you are going to gain weight. We can't predict whether it will be central weight with the Apple or Android distribution that's associated with more cardiometabolic disease, or if persons will be more likely to gain weight in the gynoid distribution. But what we ultimately worry about is primarily expansion of the visceral adipose tissue depot. This leads to tissue effects that we've already explained, but ultimately, once the local tissue level function is disrupted, there's release into the systemic circulation of pro-inflammatory cytokines, hormones, and free fatty acids that affect a variety of other tissues, including skeletal muscle, the heart, and liver, leading to insulin resistance, other lipid abnormalities, and ultimately cardiovascular disease. So a better understanding of how adipose tissue function changes with HIV, ART, and aging is needed to prevent cardiovascular disease in people living with HIV. So I'm going to briefly touch on weight gain on ART because a lot of new data has come out recently. And here you can see on the left-hand panel data from the ADVANCE trial showing compared to standard of care, which is treatment with tenofovir disoprosyl fumarate, emtricitabine, and efavirenz in blue. Persons treated with raltegravir instead of efavirenz had significantly more weight gain. And then the additional substitution of tenofovir alafenamide or TAF for TDF led to an even greater weight gain in persons over 96 weeks. This was especially true for women. On the right-hand side, this is a summary of randomized controlled trials from Gilead, and you can see in the upper left-hand panel that persons treated with integrase inhibitors did have significantly more weight gain in red than persons treated with PI or NRTI over 96 weeks of therapy. In the lower left-hand panel, broken down by integrase inhibitor, dolutegravir and bictegravir seem to have similar trajectories of weight gain compared to a lower weight gain with elvategravir, and this has been demonstrated in multiple studies. And in comparison, as a reference point on the right-hand side of the panel, we see the weight gain observed with raltegravir and efavirenz in the upper right, and on the lower right, the contributions of the various nucleoside backbone components, again, with tenofovir alafenamide being associated with the greatest weight gain. And these represent the bulk of the data that is emerging fairly well. What's important and relevant to this talk is people ask, well, how do we know what this weight is? So the advanced trial had DEXAs that were taken along with study visits throughout the 96 weeks. And here we see in the yellow and gold, for both men and women, that most of the weight gain was primarily fat gain. In persons treated with dolutegravir, there was some lean mass gain and trunk lean mass gain seen in salmon and pink. However, with efavirenz, there was essentially no lean mass gain after ART initiation. But in general, most weight gain is fat gain. And indeed, this is believed to have clinical consequences. The same participants in the advanced trial saw more than a doubling of the risk of metabolic syndrome over 96 weeks in persons treated with dolutegravir and TAF compared to efavirenz. This did not reach statistical significance when separated by sex, but I will tell you that I think this is probably a power issue, because if you look at the actual percentages, you see again at least a doubling of the risk of metabolic syndrome over 96 weeks in persons treated with dolutegravir and TAF compared to TDF and efavirenz. So how may ART and HIV affect muscle function? First, it promotes deposition of fat into the muscles, decreasing muscle quality. It reduces muscle aerobic capacity, particularly in people on ART compared to persons living with HIV who are either not on ART and HIV negative persons. There's reduced oxidative enzyme activity and increased muscle oxidative stress. Interesting, there's no change in skeletal muscle fiber composition or number, as occurs with age, at least in the short term. And we'll see these data in more detail, but basically this is telling us that the quantity of lean mass is not decreasing at a greater rate in persons with HIV, but the quality is significantly changing and in fact worsening. And this can be shown, and we'll see on some pathology slides, by internalized myonuclei with reduced nuclear PPAR gamma coactivator expression, which are both two markers of premature aging of the muscle. So here in the left-hand panel, we see on the x-axis two markers of muscle function, peak VO2 and production of ATP. And regardless of the measure, if your mitochondrial function is worse, your walking speed is slower. And on the right, we see an algorithm for how this might happen, such that aging causes loss of muscle mass. Loss of muscle mass from aging leads to decreased aerobic capacity, shown by VO2 peak, and loss of mitochondrial capacity and efficiency. Those functional deficits then lead to reduced walking speed, and of course, reduced functional capacity leads to reduced mobility, disability, and mortality, as we well know. HIV and ART, though, come in again at the muscle function level, contributing an additional detriment to walking speed. And here are the biopsy data that I alluded to earlier. We see on the left-hand panel A, the red staining, which is that PGC1 expression, and in panel D, right below it, the fact that the HIV positive participants had lower PGC1 levels than the HIV negative participants. In panel B, we see the staining of the muscle nuclei in red, most of which are at the periphery of the cells, as you can see. But there are nuclei in the middle of the cells, which is illustrated with the orange circle. Nuclei should not be in the middle of the muscle cells. This is very atypical. And so you can see in panel E that the HIV positive participants did in fact have significantly more internalized nuclei than persons without HIV. And on the far right-hand column, this is showing that there's no difference in collagen, which excessive collagen deposition can lead to fibrosis of the tissues. In this particular cohort, there was no difference by HIV serostatus and collagen deposition, but the two markers of premature aging, the PGC1 and internalized iononuclei, were disrupted in persons with HIV. Coming back to our point about functional impairment with age, with ART and HIV, rather than muscle quantity loss, this is a short-term study over 5 years of people living with HIV by gender compared to HIV negative controls. And you can see, particularly for men, that the HIV positive men started out with less muscle mass overall, but that the rate of decline of muscle mass was essentially the same for the men with and without HIV, and a similar finding in the women. So the age-related component of muscle quantity loss seemed to be about the same and did not differ by HIV serostatus. What does happen, though, is people living with HIV are more likely to have fatty muscle because both age and ART contribute to fatty muscle, which leads to loss of muscle function. And in the panel on the right from Christine Erlandson and colleagues, you can see as people age, those with HIV have significantly fattier muscles than those without HIV in blue. This is evidenced by thigh muscle density from CT, in which lower density means a fattier muscle. So those lower values as you approach age 70 reflected much fattier muscles in the older HIV positive men. And then in the panel on the right, we see, again, what is the composition of the muscle. After initiating antiretroviral therapy, we see significant increases in total muscle area, so muscle quantity. But in figure 1b, no change in lean muscle area, which means the changes in muscle area related to antiretroviral therapy initiation were related to increases in fat in the muscle. So let's put it all together. We know, and this is data from Giovanni Guaraldi's cohort in Modena, that fat gain and lean loss is the rule in HIV. It's also somewhat the rule in aging, but we know, again, from other studies, particularly this one with Phil Grant's group, that this can be greater than expected for age. So in the top panel, this is specific to fat. You see in blue, fat gain with antiretroviral therapy initiation in people living with HIV that does not plateau over a number of years. It keeps increasing and is much greater than the fat gain that occurs in persons from the general population in red. So this is indeed greater fat gain than expected for age while on suppressive antiretroviral therapy. And the potential implications of this are pretty significant, and that increased fat mass and decreased lean mass and increased fatty muscle increase risk for obesity, sarcopenia, and their complications, particularly sarcopenic obesity, and we'll talk about that more on the next slide. So how may HIV, ART, aging, and obesity interplay to contribute to sarcopenic obesity? Well, I think this is a nice figure because you see at the top the effects of aging on the left and obesity on the right, whether it be disruption of metabolic rate, hypogonadism, or with obesity, fat accumulation and insulin resistance. These then affect the function of both the muscle and the fat, leading to reduction in muscle quantity and aberrant adipose tissue function, and weight gain leading to sarcopenic obesity, which we know that from the general population is associated with increased mortality compared to having sarcopenia or low muscle mass or obesity alone. And HIV and ART, as we've just talked about, play into both the muscle and tissue function here. So again, it's a scenario where we're laying on top of age and obesity related issues, the contributors of the virus and of our therapies. And I just want to highlight that sarcopenic obesity is defining the relationship between muscle mass and obesity, but there may be a better measure for people living with HIV, particularly since we just talked about how HIV and ART affect the muscle quality and not the muscle quantity, and that would be dynapenic obesity. And dynapenic obesity is the relationship between the muscle quality and obesity, And these are actually defined using things that are available in clinical practice, such as hand grip strength and waist circumference, whereas sarcopenic obesity requires more of a research analysis with a quantification of muscle mass by imaging. Determination of dynapenic obesity is something that you can do in the clinic. And we see the Venn diagram here showing us that some people may be sarcopenic and dynapenic. They may have low muscle mass and poor quality muscles, but you can be in either category separately. And so since HIV and ART are affecting muscle quality more, perhaps the dynapenic spectrum is a place for us to better assess functional relationships in our folks living with HIV. So just some take-home points. Aging, weight gain, HIV, and ART all contribute to morbidity and mortality in people living with HIV, but the mechanistic intersections are only beginning to be understood. The virus-specific effects on muscle and fat are independent of virologic suppression, so alternative therapeutic targets may be needed. We see that there is a risk for excessive weight gain for some people on integrase inhibitors and tenofovir alafenamide, but the therapeutic strategies to treat or avoid this have not yet been determined. And the benefit of using these agents may ultimately outweigh risk, so we really need to see where this research goes. And then finally, fat gain and lean mass loss in people living with HIV on ART may combine with age-related changes in these tissue depots to increase the risk for sarcopenic or dynapenic obesity and its sequelae. And with that, I would like to thank you.
Okay, that's great. Jordan, thank you very much. Wonderful talk and a lot to think about and potentially discuss. So I urge the viewers to go to the live Q&A function in the on-air program and start posting some questions. I put a couple down there to start us off, but I know there's a lot within that to get people thinking. So I look forward to those questions. It's now my pleasure to introduce our second speaker, Dr. Giada Bastiani. She is an associate professor of medicine at McGill and the McGill Research Center, did medical school and residency at the University of Padua, and number of fellowships in very prestigious organizations, including Harvard, University College London, University of Bordeaux, and the Lady Davis Institute in Montreal. Giada's research focuses on fatty liver disease, liver fibrosis, and other liver conditions, especially in persons at higher risk, including people living with HIV and diabetics and others. She's won numerous international awards and is a steering committee member of the Canadian NASH network, non-alcoholic steatohepatitis, and the sole North American representative to the European AIDS Clinical Society. It's a real pleasure to introduce her, and her title will be Fatty Liver Disease and Implications for Aging.
Hello, everyone. I'm Giada Sebastiani from McGill University Health Center, and it's a pleasure to present this lecture on fatty liver and implications for aging for this important international workshop. These are my disclosures. In the last years, there have been important change in the epidemiology of HIV due to aging. According to the CDC, nearly half of the people in the United States living with HIV are now aged 50 and older. This has important implications in terms of changing of the comorbidities associated with the disease. Deaths caused by liver diseases now have increased 10 times in the post-antiretroviral era, while AIDS mortality has fallen over 90 times. This has changed the face of the epidemiology of the disease. In terms of liver disease, the progression is usually characterized by steatosis, which is fatty liver or fibrosis, and NASH, significant fibrosis, cirrhosis, and hepatocellular carcinoma. But in the context of HIV infection, the progression of liver disease may be more complex. First of all, the metabolic risk factors, which are usually importantly associated with the pathogenesis of the disease, are more frequent in people living with HIV. Then other etiologies like hepatitis C or B are also more frequent. And importantly, there are factors that are unique to the HIV population, particularly the prolonged use of antiretrovirals, which have to be used for the whole life, and HIV-related factors. For example, it's known that HIV viral load can affect liver damage, and HIV itself may actually have pro-apoptotic effects on the hepatocytes. Non-alcoholic fatty liver disease represents the most frequent liver disease currently at the global level. It is defined as fatty liver disease. Fatty liver disease means that at least 5% of the hepatocytes have to be fulfilled with steatosis, with fatty liver. And within this spectrum, there are two different etiologies: secondary fatty liver disease and non-alcoholic fatty liver disease. NAFLD is a term umbrella which encompasses two main diseases, which is non-alcoholic fatty liver, also known as hepatic steatosis or simple hepatic steatosis, which is usually non-progressive and doesn't lead to cirrhosis and related complications, and NASH, non-alcoholic steatohepatitis, which is instead the evolutive counterpart of the disease, which may lead to cirrhosis and related end-stage complications. In both cases, the main factors for the pathogenesis of NAFLD is insulin resistance. And insulin resistance, which we may observe and all in diabetes, obviously, and all the related metabolic comorbidities like obesity, hypertension, or dyslipidemia. The epidemiology of the disease is quite different in the context of HIV infection. You see here in the general population, about 25% of the adult population has NAFLD, about 5 to 6% has NASH, and 1 to 2% of this population will actually evolve to cirrhosis and related end-stage complications like hepatocellular carcinoma. But the prevalence of in HIV is much more important. Several studies that we will see in details showed that up to 48, even 55% of people living with HIV have actually non-alcoholic fatty liver disease. 10% may have NASH, and 4%, so 4 times more, may have liver cirrhosis, compared to which is 4 times higher than the general population. In terms of elevation of transaminases, in most of the cases, the elevation of liver transaminases that we observe in HIV infection is actually caused by NAFLD. The first concept is that liver transaminases are frequently elevated in HIV monoinfected patients. Up to 20% of them can have chronic elevation of liver transaminases. And if you see in the studies, in most of the cases, this elevation is actually due to NAFLD. So in clinical practice, elevation of liver transaminases is frequent in HIV monoinfected patients. And in most of the cases, this is actually associated to NAFLD. If we look this into details of the histology, we can observe that non-alcoholic steatohepatitis NASH is actually the most frequent histologic abnormality that is responsible for this elevation of liver transaminases. In these studies, that are all histological studies, you see that up to 64% of patients with chronic elevation of liver transaminases, HIV monoinfected, have actually NASH on liver histology. So it's a very frequent condition and possibly responsible for most of the cases of elevated transaminases in HIV monoinfected patients. How we can diagnose and evaluate NAFLD and NASH? The two main characteristics that we want to identify are steatosis and liver fibrosis. Steatosis and liver fibrosis can be both identified with the invasive liver biopsy, which is considered the gold standard of reference, but there are several imaging techniques also to diagnose these two conditions. Here you can see a fibroscan transient elastography, which is much used in clinical practice, but also MRI, for example. This is a MR elastography. And there are also several other techniques, including ultrasound and CT scan for steatosis, and also some biomarkers like NAFLD fibrosis score, and especially the FIB4 has been quite used in several etiologies of liver disease, including validation in HIV immunoinfected patients. Why we are so interested in liver fibrosis? In any etiology of liver disease, liver fibrosis is the most important prognostic predictor in patients. It's the most important predictor of mortality. In this study, which I collaborated, we actually found in a meta-analysis that liver-related mortality exponentially increase with the increase in fibrosis stage. And you can see here that from stage 2, there is an increase which then becomes exponentially when we move from the stage 3 to the stage 4, where stage 4 is considered liver cirrhosis. So liver fibrosis, especially important for the prognosis in our patient with non-alcoholic fatty liver disease. NASH remains a histological diagnosis. It's important to underline that if we want a true diagnosis of NASH, we need the liver histology. According to guidelines, NASH has to be diagnosed by a liver biopsy because there are two especially characteristics at the histological level that cannot be found with the non-invasive tools currently available, especially ballooning and lobular inflammation. So while we can, with the invasive tools, evaluate fibrosis and steatosis, these two histologic characteristics cannot be evaluated with non-invasive tools. For that, we will need the liver histology. However, in clinical practice, there are some predictors that we can use for NASH and also associated fibrosis. If a patient has fibrosis, in fact, like determined, for example, with the biomarker FIB4, it's obvious that he cannot have simple steatosis, but he will have probably NASH because simple steatosis doesn't give fibrosis while NASH gives fibrosis. There are other variables that are associated with NASH and with fibrosis, including older age, which is important to this lecture in aging with HIV, sex, for example, in males, there is more risk, especially compared to premenopausal females. Race, we know that Hispanic population is at higher risk for NASH and also associated fibrosis, and also all the components of the metabolic syndrome, especially if they are combined. When there is a metabolic syndrome, there is much higher risk for NASH and for fibrosis. Also, low platelets, indication of possible underlying cirrhosis, and persistent elevation of the liver transaminases. When we look at the studies investigating the prevalence of NAFLD in HIV immunoinfected patients by imaging, we can see that according to the tool that we use, for example, ultrasound, CT scan, or MR spectroscopy, we can have different prevalences, but overall, there is a clear tendency for the prevalence to be much higher in HIV immunoinfected patients compared to the general population. We can see here the UK cohort, the Italian cohort from Dr. Guaraldi, and the US cohort from Jennifer Price. When we consider the studies that have instead used FibroScan with the control attenuation parameter, which is a tool very much used to diagnose hepatic steatosis, we can see that if we use the same tool, the prevalence is quite similar, according to small differences, probably due to different use of cutoff values, but you see very similar and again higher than that reported in the general Canadian population. This is the study from Hugo Perazzo in Brazil. This is my Canadian study with my fellow Tom Pembroke, and this is the German cohort used also with the CAMP. In all the studies, there have been also evaluation of the main cofactors associated with NAFLD in the specific setting of HIV infection. And if you see in all the studies, the main reported factor associated with NAFLD is BMI, which is quite similar to what we find in the general population. But this is confirmed again in the situation of HIV, which is very important because this in clinical practice tells us that our patients should maintain normal weight as much as possible. Other associated factors reported are triglycerides and diabetes. in this very interesting study, which I collaborated from Dr. Guaraldi from Modena, which is very pertinent to aging in HIV, it was even found that NAFLD diagnosed with CAP is a predictor of frailty in HIV non-infected patients. And you see here that if you use the frailty index score as fit, frail, or most frail, patients who have higher degrees of hepatic steatosis or fatty liver, they are more likely to be actually most frail. Very interesting for aging in HIV. In terms of the natural history of the disease, this is the data that we have actually developed in Canada with the liver in HIV cohort, which is a routine screening program for fatty liver and fibrosis using FibroScan with CAP. As you can see here, the first finding in this first longitudinal data evaluating the natural history of the disease in the specific setting of HIV infection, we found that fatty liver hepatic steatosis, actually, the incidence is higher in HIV non-infected patients compared to those co-infected with hepatitis C. And on the other hand, if you move on the right, you see that in the case of HIV non-infection, the presence of hepatic steatosis is actually associated with a much higher incidence of fibrosis, so with important implications for the prognosis, while that was not the case in HIV HCV co-infected patients, where the main driver of fibrosis progression, as expected, was HCV RNA. Another study where we investigated, again, the natural history of the disease in the specific setting of HIV infection in the live HIV cohort, we found that NAFLD is associated with the development of important metabolic comorbid conditions, especially diabetes. You see here that patients with NAFLD as baseline without diabetes, they have a much higher risk of developing diabetes compared to HIV non-infected patients without diabetes at baseline. And similar findings were observed for dyslipidemia. So if a patient has NAFLD at baseline and it doesn't have dyslipidemia, it has a higher risk of developing dyslipidemia. These findings are important for risk stratification, especially considering that people living with HIV have higher cardiovascular risk in general. Is there something that we can do regarding this condition? In terms of treatment of NAFLD, the cornerstone that has been clearly suggested by all the guidelines is losing weight. And I think this is particularly relevant also to the HIV field, considering that several studies, as we have seen together, found that BMI is the most reported predictor of NAFLD. So the more the patient loses weight, as you see, for example, more than 5% of the body weight, 7 to 10, even more than 10% of the body weight, and the more we can improve all the characteristics related to NAFLD. For example, if a patient loses more than 10% of the body weight, we can actually have positive effects and changes in liver histology in both NASH and also liver fibrosis. So this is the cornerstone. Is there something else that we can do? In this study that we recently published in AIDS, we have piloted the use of vitamin E in the setting of HIV non-infected patients for the treatment of non-alcoholic steatohepatitis. In 27 HIV non-infected patients, we administered 800 units of vitamin E for 6 months, and then we followed up without the intervention for other 6 months. Vitamin E has been given 800 units like it is recommended in the general population, HIV non-infected by the guidelines. Our results were very positive because, first of all, we found that patients during the vitamin E treatment had important regression in terms of steatosis or fatty liver. So at the baseline, no one was obviously without fatty liver because to be included, they have to have NASH. But at the end of the 6 months treatment, already almost 1 in 5 had no fatty liver. And if we look on the right at the changes on the liver transaminases, most of the patients had elevated transaminases at baseline, while at the end of the treatment, most of the patients actually had normal transaminases. So very interesting results, probably due to the fact that people living with HIV have a lot of oxidative stress, and vitamin E is an antioxidant. And this is a commentary from Dr. Guaraldi that probably vitamin E could be considered a bridge therapy while we wait for other and better treatments. Another very important study and published in Lancet HIV, where another intervention has been piloted in the setting of HIV monoinfected patients, is tesamorelin, which is a medication used to treat lipodystrophy. And because lipodystrophy is associated with NAFLD, they have piloted the use of tesamorelin as a treatment for NAFLD in HIV monoinfected patients with a randomized double-blind multicenter trial. And you can see here that there have been significant changes in liver fat, in hepatic steatosis, and also, very interestingly, there's been much less progression of liver fibrosis in a period of 12 months compared to placebo when we consider patients treated with tesamorelin. So interesting results. Another interesting concept that has been piloted by the group of Juan Macias in Spain, considering that antiretrovirals can be a pathogenic factor in liver disease in HIV infected patients, they actually looked at changes in liver steatosis in fatty liver after switching efavirenz to raltegravir. This study has been conducted in co-infected patients, so it is possible that the findings in HIV monoinfected patients are not the same, so this has to be studied, obviously. But what is interesting is that in the raltegravir group, there's been a much higher proportion of patients without steatosis after 48 weeks from the switch. This data should be confirmed, as I said, in HIV monoinfected patients, considering especially recent findings on the increase in BMI and body weight in patients on integrase inhibitors, especially dolutegravir. According to the guidelines, you can see here the guidelines, the recent ones from EACS 2019, which I participated and have been recently published also in HIV medicine. You can see here that the cornerstone is lifestyle modification, as we said initially. So conserving a good body weight, this is very important also in the setting of HIV monoinfection. Proven efficacy, vitamin E has also been piloted, as we saw together before, in the setting of HIV monoinfected patients. Pioglitazone is recommended in the HIV in non-infected population by guidelines, but don't have strong data in the setting of HIV, but it's an option. And bariatric surgery in those who are eligible with morbid obesity. Especially pharmacotherapy and bariatric surgery should be considered in patients with severe disease or significant disease. For example, NASH with significant fibrosis, and NASH with less severe disease but high risk for progression, especially diabetes, metabolic syndrome, or persistently elevated ALT. In the guidelines also, it is mentioned something related to the antiretroviral drugs. The drugs should not be used in patients with NAFLD. And they also mentioned that we should consider the use of lipid-neutral regimens in individuals at risk or with NAFLD. And finally, screening. The concept of screening has actually emerged recently in an important way for NAFLD. Recent guidelines of the American Diabetes Association, published in 2019, for the first time recommend screening for NAFLD-associated fibrosis in patients with diabetes. And accordingly, these guidelines from EACS have actually mentioned the concept of screening for NAFLD in HIV-positive patients when there are metabolic risk factors or elevated transaminases. So the concept is that HIV monoinfected patients should be considered at-risk population for NAFLD. And accordingly, if you diagnose NAFLD, you have also to establish the staging of liver fibrosis, so important as we mentioned before, and eventually referral to specialists as indicated. In summary, NAFLD is the most frequent liver disease at the global level. 25% of the general adult population is affected. But this proportion goes much higher in HIV monoinfected patients. It can go up to 55% according to different studies. This means that HIV monoinfected patients should be considered a population at risk for NAFLD. Diagnosis of NAFLD and NASH, especially NASH and fibrosis, is based on clinical predictors, non-invasive tests for liver fibrosis, and when needed, liver biopsy. But high suspicions should be considered in clinical practice in case of elevated ALT and or overweight. In HIV-positive patients, NASH can progress to liver fibrosis to 50% of the cases, which is a much higher proportion than the general population, as we said before, and 4% cirrhosis, which is 4 times higher than what we found in the general population with NAFLD, and related end-stage complications. Recommended treatment for NASH includes lifestyle modification as a cornerstone. We have to maintain normal body weight in all patients, and pharmacotherapy should be considered in more severe cases, especially NASH, and if there is associated liver fibrosis. Screening for NAFLD should be considered and recommended in HIV monoinfected patients in case of metabolic comorbidity and elevated transaminases. Thank you very much for your kind attention.
Okay, I believe we're back to me. Another fantastic talk. So 2 really strong talks today. Thank you both very much. We've had a very active Q&A process here. So I'm going to try and lead us through this and see what we can get covered. Some of these are for both of you and some are for individuals. Let's start with a couple that were done individually. So Jordan from Tristan Barber, great talk. Evidence to show that those with raised inflammatory markers, and if so, which one, or raised immune activation markers gain more weight than others. Are inflammatory pathways the right place to target therapeutics for weight gain? And if so, are there some other mechanisms that we need to explore, like the microbiome? So he said, again, thanks for a great talk. And what are your thoughts here?
That's a good question, Tristan. So there are data to show that lower CD4 count at start of antiretroviral therapy and higher viral load are associated with greater weight gain. I don't know that studies have specifically looked at the additional association with specific inflammatory biomarkers, but certainly the setting of greater HIV disease severity, you would expect higher inflammation markers for some folks, particularly perhaps IL-6. So that is definitely something worth looking at. And I do think that other mechanisms are underexplored. We don't know why some people gain extreme amounts of weight, much greater than you would ever consider to be a return to health within a short period of time after starting antiretroviral therapy. And it's usually fairly, upsetting to the patient. So we need to figure that out. Microbiome plays so many roles that we don't understand, especially when the person is already obese or has other comorbidities that are affecting their microbiome. You layer HIV on top of that, that's certainly possible. Also, differential drug potential, PK, et cetera, with changes in gut function. I think that all of these are fair places to start. And then we really don't understand central mechanisms of weight gain in this setting either, and whether there could be some central mechanism playing a role.
Great, thank you. Let me pose a question to Dr. Sebastiani, but also say, if you care to add to what Jordan has said, please feel free to do so. The question would be from Joe Margolick. Do you have any thoughts about how HIV might exert its pro-apoptotic effects on hepatocytes?
Yes, very, very nice question. Thank you for the question. So there are several publications actually on the basic science, field showing that HIV and HIV glycoprotein GP120 ligation with CXCR4 on hepatocytes actually can upregulate the TNF-alpha pathway for inducing apoptosis, the trail pathway. So the trail-mediated apoptosis, which is linked to TNF-alpha, mediated by GNK12. So this actually induces a direct apoptotic effect on the hepatocytes. And this then in clinical practice, I wouldn't say in clinical practice, but in clinical studies, could probably, be showed in the fact that some of the studies have shown that possibly a residual viral load can be associated with NASH and with NASH severity. So these two can be related. Thank you for the question.
Great. Jordan, so another question for you from Jessica Castillo. Considered it a great talk. And what clinical outcomes are associated with dynapeptic obesity? Should we be screening our patients in clinic for dynapenic obesity?
So far, the types of relationships that are being shown in terms of clinical outcomes are similar to those with sarcopenic obesity. So overall, mortality, functional decline, the relationships with there is much less published about dynapenic obesity. I'll start there, but it seems to, track closely to sarcopenic obesity in terms of the types of deficits. And I think you might expect that. It's just a little bit more of a functional measure compared to a muscle mass quantification playing into the formula. But both of those, deficits in function and or mass will lead to similar outcomes of poor physical function, frailty, et cetera. So I think we can get at mostly the same endpoint by using those two. It's just certainly the equation for dynapenic obesity is much easier to solve in the clinical setting.
A quick follow-on from Christina Somas. Do we have good ways of measuring dynapenic obesity? What would be your thought there, Jordan?
So the recommended formulation is to measure grip strength and waist circumference. And so the dynamometer that you can test grip strength is fairly available in clinical settings. And certainly anybody with a tape measure can take a waist circumference. So I think it's pretty easy and straightforward.
Great, thanks. Coming back to Dr. Sebastiani from Julian Flutz. Old data on vitamin E in patients with lung cancer had an increased risk of overall mortality. Since patients living with HIV have increased risk of lung cancer, are you looking at signals of lung disease in your treated patients?
Thank you, Julian, for the question. It's a great question, actually. So our data, our pilot data for the moment, they are, as you know, they are short term. So we're really looking at efficacy in a short term. It was a pilot study. So I don't have data on the effect for lung cancer. I have to say that the data that have been produced for the association of vitamin E with some risk of cancers like prostate cancer, that like the SELECT study, have been questioned. So there are big data, but there have been also some questions on the real causal relationship. But I think this is a very important point. I think what Giovanni Guaraldi was saying, to use this vitamin E as a bridge therapy, maybe for short term, until we have more appropriate antifibrotic medications, which I want to underline that they are not yet tested in the HIV positive population, this could be a way to approach. Thank you for the question, Julian.
Okay. We'll swing back to Dr. Lake. We have lots of questions here. We'll probably run out of time before questions. John O'Brien poses the question: is there potential for increased fat, truncal fat in particular, to act as an HIV reservoir, potentially through enhanced immune activation, and therefore lead to the possibility for increased viral replication?
So thanks for that, John. I think, we know what we know about the HIV reservoir really in fat really comes from Dorothy Lewis's work and the group in France as well, who has sort of been working on this parallel. And mostly what we know is from the subcutaneous depot, because it's easy to get subcutaneous fat biopsies. But there is some data coming out, particularly from Lewis's group, about visceral fat in the primate models of HIV. What I would expect from the subcutaneous fat data is that while, per sample of fat, you see a lot less HIV than you would expect in a lymph node, for example, simply due to fewer immune cells congregating, et cetera. If you add up all the fat in the body, that provides potential for a very large reservoir, larger for some people than others. But we know that certain classes of antiretroviral agents do not penetrate well into the adipose tissues. And so I do think that it's an understudied reservoir and that it may have potential for, persistence of the virus that we don't fully understand. And I hope to see more work in that arena as well. But I think that if you are seeing this in subcutaneous fat, there's no reason why you wouldn't see this in visceral fat, especially when we're thinking about viscera like the liver that are getting a lot of immune cell influx. And hepatic stellate cells can be infected by HIV, so that's also causing local tissue inflammation near adipocytes that can facilitate a reservoir.
Yeah, and it's also interesting from the aging community in general, the embedment of SASP cells with increased inflammatory production, these so-called senescent cells, sometimes lymphocytes, sometimes not, in fat tissue, providing an increased environment potentially for tumor growth and other things. So it's got a really interesting question. Giada, coming back to you, I'm going to link two of them here. Should there be a required screening for the presence of NAFLD or NASH on persons with HIV? And
yeah,
well, let me, because it's got a couple of thoughts here. Let me get the whole thing out. And what might be the age of the person that you'd start looking, or the type of laboratory exam you might use, or the frequency? And is CD4 count an important thought here? The nadir CD4 count, an important thought. And honestly, I'm not sure where we are with time. So that was a sort of maybe a bigger question. Maybe you could kind of pull it together in a
Sure. Yes, thank you very much for the question and for the great moderation, if I may say. So I think this is a very critical point, in nowadays. So I think that also as NASH community, of scientific community, we are really looking mostly at this point to screen and to identify those patients with fibrosis, because fibrosis is really the most important prognostic factor which affects NASH and NAFLD. So in terms of what we would do in clinical practice, what we would recommend, also it is in the EACS guidelines, it is really to screen, for example, with simple biomarkers like FIB4, which is based on age, platelets and transaminases, patients that are at higher risk. Which are these patients at higher risk? In the HIV world, most of the data thus far show that those with chronic elevation of transaminases or with metabolic comorbidities, especially obesity and diabetes should be the ones who should for sure be targeted for screening with the FIB4. And then through the cascade, if a FIB4 is positive or not completely negative, then you can go to more specific tests. For your question on the CD4, I think this is the NAD44, it's a very interesting topic. There are only a few studies in the literature that have been associated nadir CD4 with the NAFLD, but they are mostly cross-sectional. I think we need, and in most of the studies, the BMI, the main predictor of NAFLD, but I think we need the prospective studies really to assess the effect of antiretroviral therapy and CD4 nadir on the disease.
Thanks very much. And so while we have you, Giada and Jordan, there's been a number of questions that might impact, that you might both be able to answer, in fact, both your lines of work. Let's end with one. I think we have about 3 minutes left, so maybe a minute and a half each. Just thinking about diet. There's a lot of folks in the audience that are interested in how might we use diet, or how might poor diet impact both the ideas that you're discussing about. Giada, why don't you take the first shot here?
Sure, thank you. So this is also another critical point in the NAFLD literature. So the studies thus far in the general NAFLD and NASH show that Mediterranean diet, it's actually, there has been a randomized control trial, Mediterranean diet versus low-fat diet, and Mediterranean diet has a significant positive effect in reducing the fat in the general NAFLD. We don't have this data in HIV, but I think this is a very important point. In fact, the guidelines for NAFLD recommend lifestyle modification and diet as first-line therapy. I want to underline that in a recent publication from my group, we actually showed that lean NAFLD is quite frequent in the setting of HIV. So about 25% actually of patients with NAFLD in HIV are lean. In that case, we may need to target a different kind of situation, but for sure, having a good BMI and possibly study the effect of the Mediterranean diet, I think it's something that we should look in the HIV world as well. Thank you.
Oh, thank you. Jordan, any sort of closing thoughts you can give us around the impact of diet here?
Well, I think, diet, lifestyle can never be underscored enough, right? If we don't give our bodies healthy things with which to live on, bad things happen. That's been shown in a lot of clinical settings. And so, things that are pro-inflammatory, et cetera, contribute to the problem, and certainly contribute to microbiome issues that, have downstream effects. I would like to second this comment, though, about lean NAFLD. In our cohort, which I presented here last year, almost half of our patients with fatty liver disease were non-obese. And so there's certainly something else at play. That NAFLD in HIV is not completely traditional NAFLD. That would be, lean NAFLD would be rare in the general population. And so we need to understand these mechanisms better to understand what targeted therapies may need to be specific to people living with HIV. And then, of course, if you also have traditional risk factors, you need to modify your traditional risk factors. But the lean NAFLD is very interesting.
Yeah, great. I suppose we could tack on the notion of exercise onto that as well. And if we're thinking lifestyle interventions, and any particular thoughts about types of exercise in people living with HIV, or is that work we need to do, either of you?
So if I may say, for the NAFLD site, according to the guidelines, recommend for NAFLD, general NAFLD, 150 to 200 minutes per week of moderate aerobic exercise divided into 3 to 5 sessions. This has been well studied, I would say, in the general non-HIV NAFLD. I think I think this all this data that we heard, it is possible that this would really be nicely applicable also the HIV world. But I think we need more ad hoc data, and I would like to go back to the comment of the colleague, very important and excellent presentation, actually, if I may say, on lean NAFLD. It's more frequent in HIV, so we need more targeting interventions.
Exercise and a microbiome, Jordan?
Well, there are studies ongoing, and I'm not a microbiome expert, but I think exercise, again, it's just like diet, as you said, it's easily tacked on. We should be doing the things we know are good for us. And outside of HIV, as people age, we encourage them to do what they need to do to maintain muscle mass and minimize weight gain. It's the same situation. We wouldn't have different recommendations. Now, there are subpopulations of people with HIV who, similar to frail geriatric populations or other populations with limitations, exercise may not be as safe. Diet may not be as safe, certainly in an extreme way. But for most people, diet and exercise should be kind of the cornerstone of health in general, and adding other things on top of that.
Yeah, I mean, I think that last comment is one I've thought about too. I'm getting older, and I know I can't exercise the same way I used to, and there is a safety issue too as we think about this. So we're going to need, I think, really good thinking and research about how to target these things for our folks living with HIV. Okay, I'm told I should round up, so I'm happy to do so. I want to thank both speakers for really very strong, tremendous talks. I want to thank the audience for a very active Q&A session, and I thought very stimulating and a great setup for the rest of the day. So thanks very much.
Thank you. Thank you.
Thank you.